All right, so in this video, we're going to talk about deglutition or swallowing, right? So the process of swallowing involves the tongue, soft palate, and pharynx. We talked about the tongue in previous videos because we said that when you swallow, it elevates and it kind of forces that food or bolus towards the back of the mouth. And if y'all remember, another name for the back of the mouth was pharynx. Now we have these pharyngeal constrictor muscles that actually help to squeeze that bolus downward. So it goes from like the nasopharynx, the oropharynx, down to the laryngopharynx, and then it squeezes that bolus down into the esophagus. Now if y'all remember though, what prevents that bolus of food from going down into the larynx is our epiglottis, and we'll see a picture of that here in a minute. Now, what's kind of interesting though is that swallowing requires 22 muscle groups. So not only is it your tongue, but it's also muscles that are associated with your mandible. It's also your pharyngeal muscles, and there's some esophageal muscle as well along the length of the esophagus. So what's interesting is it requires so many muscles to swallow. Sometimes if people have like nervous system injury or some kind of nervous system problem, it can show up as difficulty swallowing or dysphagia, right? Because it involves so many different muscles. So it starts with this buccal phase. Now the buccal phase, buccal just means cheeks, right? So at the level of the cheeks, that part of your mouth, the buccal phase requires the contraction of your tongue. Your tongue is under the control of your hypoglossal nerve, which is cranial nerve number 12, if y'all remember that. And so it requires both that tongue muscle to work and your hypoglossal nerve to be functioning as well. But that would be involved with the buccal phase. This pharyngeal esophageal phase is essentially involuntary, right? Because it requires the use of smooth muscle. And so there are some other nerves that are involved with the contraction of your pharynx and esophagus. But what's interesting, though, is that the control center for this phase of swallowing is in the medulla and the lower part of your pons. So if you guys remember, the medulla and pons are part of your brainstem. So swallowing requires a brainstem. This is also one of the reasons why we need a brainstem to live, because you can't ingest food without swallowing, right, unless you're on a feeding tube. And that requires the use of your brainstem, okay? But it is under involuntary control, so you don't have to think about it. Once it exits your mouth towards the pharynx and esophagus, now we're just talking about reflexes that move that bolus of food down towards your stomach. So if we start here with the buccal phase, you guys can see how the tongue elevates. And if you think about, like, when you do swallow yourself, like, if you kind of think about yourself swallowing or try it, you know, you can feel the tip of your tongue touch just behind your upper incisors. And if you really, like, think about what's happening there, you can feel it start to protrude backward, right? So it elevates and then protrudes backward. And what that does is it forces this bolus of food. I don't know what this is. Maybe some like saag paneer or some lettuce. I don't know. But now it's in a bolus, right? Because it's mixed with saliva and mucus, so it's a nice sticky little globule. And so then what happens next, you guys, is that forces it back towards the pharynx. And if you guys remember, the uvula here prevents this bolus of food from entering the nasopharynx. So when you swallow, the uvula will also elevate and close off the nasopharynx. And then once it gets to the pharynx, then we're going to enter this pharyngeal esophageal phase where the pharynx here, which is the back of the throat, that starts to constrict. And it constricts from a superior to inferior manner. And so what that does is it's going to force this bolus of food downward towards the esophagus. But part of this phase also is you need to have the epiglottis closed. So if you guys remember, the epiglottis is that sort of smaller little tongue here that sits atop your voice box or larynx. So when you swallow, the epiglottis actually closes off the opening to your larynx. That way this bolus of food can continue down the esophagus instead. Now the esophagus is just a muscular tube that essentially can help propel through peristalsis that bolus of food all the way down to your stomach. And there's two sphincters associated with the esophagus, right? This one they're showing here is an upper esophageal sphincter. And we'll learn about why that makes sense. But this upper esophageal sphincter, once the bolus of food goes beyond that, it constricts and it closes off. That way the bolus of food shouldn't come back, right? Sometimes it does. That's when you kind of like burp up a little bit of food. But for the most part, this upper esophageal sphincter should effectively prevent, material from regurgitating or coming back into your throat. So if we can follow this down, right, you think about, whoa, where are we now? Well, the esophagus continues all the way down your neck. Then it goes back behind the heart, so posterior to your heart, but anterior to your vertebrae, right, in the thoracic cavity. And then it keeps going down your thoracic cavity, like your lungs would be out here, your heart would sit right on top of this. And that esophagus continues down, 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 and it goes through the respiratory diaphragm, which would be here. So if you guys remember, the respiratory diaphragm is that sheet of muscle that separates your thoracic cavity from your abdominal cavity. And there's actually a hole in that respiratory diaphragm. And we call that hole the esophageal hiatus. And that allows for the esophagus to actually go through the diaphragm to get into the abdominal cavity and reach the stomach, right? And so then you might wonder, well, how is this bolus of food getting down, right? Like it can't just be gravity, because you can obviously swallow things while maybe you're laying on your back or like being upside down, right? So it's some muscular contraction going on here. But is this under conscious or unconscious control at this point for the esophagus? Unconscious, you got it, right? So it's going to involve reflex centers that are either local or long reflexes that involve your brainstem. And if it's a local reflex, all that's happening here, you guys, is we have stretch receptors along the length of the esophagus, so that once the inside of the esophagus is stretched, that causes a muscle contraction to occur, and that way it forces it forward, right? And so then think about, okay, well, this bolus goes to the next section. This section is going to get stretched, and then that section is going to contract, and it's going to keep forcing it downward, okay? So there's another sphincter down here, though. This one's called the lower esophageal sphincter, or LES. It's also called the cardiac sphincter, right? And the reason why it's called either of those is, well, it makes sense. It's the lower of the two, right? Just because there's an upper esophageal sphincter. And the reason also why it makes sense that it's the cardiac sphincter is that it's right by the left ventricle of your heart. So your heart sits right here. And so it turns out your stomach and your heart are side by side. And so what's interesting is that people often mistake heartburn for a heart attack, or vice versa. They might be having a heart attack and they think it's heartburn, because essentially, the stomach and heart are side by side. So that's that lower esophageal sphincter. It's going to be more important in terms of regurgitation of material than the upper esophageal sphincter, because if you think about it, it's right here. It's right on the stomach, right? And you think about, well, what's in the stomach? Well, a lot of acid. If y'all remember, stomach acid has a pH of 1. Right? So it's super acidic, and it could potentially burn through the stomach lining, but there's a nice mucus layer that protects it there. So if you follow this down, we see the circular muscles contract, the lower esophageal sphincter relaxes, and that way this allows this bolus of food to kind of slide in the stomach here. And there's nothing graceful or beautiful about digestion. It's just kind of nasty. So this green bolus of food enters the stomach. Then what happens, right? Well, what's kind of cool here today, guys, is once this bolus of food enters the stomach, we have mechanoreceptors and chemoreceptors that can receive the stimulus that food is now present in the stomach. And if you guys remember, that was the thing that helps to coordinate reflexes so that the stomach can start to, begin the process of digestion by releasing acid and enzymes. So if we look at the stomach anatomy in kind of some more detail here, we want to divide it by zones, right? So first of all, we want to look at the edges. So this smaller edge between the esophagus and the duodenum of your small intestine, this one's called the lesser curvature. So it's the smaller kind of curvature here. This one on the very outside is called the greater curvature. And these are significant because this is the place where omentum attaches. So if you guys remember, omentum was one of the mesenteries, so it's actually made of serous membrane. And it's basically what helps hold the stomach in place. So attached along the lesser curvature, you'd actually have lesser omentum, which goes up and attaches to the liver. So the stomach's actually anchored to the liver itself via the lesser omentum, which attaches to the lesser curvature. The greater curvature has greater omentum, and this actually goes all the way down your abdominal wall. So if you did see a dissection or maybe a surgery where they opened up someone's abdominal cavity, you wouldn't see intestines right away because there's omentum there. So you have a big old sheet of greater omentum that comes from your stomach, and it goes all the way down your abdominal wall, okay? Now, what's also kind of cool is that there's actually stem cells in greater omentum, and you can use that for certain types of grafts. So one thing that I do know about where that kind of graft is used is where they'll take a piece of greater omentum, you can graft it onto a missing bone of the cranium. Let's say the cribriform plate of your ethmoid bone. If you have some brain surgery there, they can close off that cribriform plate of the ethmoid bone with a little piece of omentum from your abdominal cavity, and that slowly over time will turn into bone, which is actually kind of cool. And I don't know who discovered that or figured that out, but I think that's kind of neat how you can take an abdominal tissue, graft it onto your skull, and it can turn into something like bone. So those are the kind of curvatures, right? Lesser curvatures attached to the liver, greater curvatures attached to abdominal wall. And then what we find then regionally is this top part is called the fundus. And so anytime you see this word fundus in anatomy, it just means sort of the top sort of curvature of an organ, right? So there's a lot of funduses around the body, and we'll talk about some, like there's a fundus of the uterus and that kind of stuff, right? So the fundus is clinically significant because this is where food is first held when it enters the stomach. So what happens is, if you look at it here, it kind of looks like a big old pouch. What happens is that food is actually held in that fundus pouch. But there's also a problem here too, guys, is do y'all remember, how did the esophagus get to the stomach? Like, what would normally cover this little area right here? Y'all remember? The respiratory diaphragm, right? And then how does the esophagus get through that diaphragm? There's a hole, right? And that one's called the esophageal hiatus. Have you guys heard of a hiatal hernia before? So a hiatal hernia is when the fundus of the stomach herniates through the esophageal hiatus. And so you're saying this top part of the stomach can actually be below your left lung. So if you ever felt like you ate too much and it's hard to breathe, you know, maybe it's your stomach just kind of pushing up below your left lung. No, I'm just kidding. But we'll talk more about that later. So this region over here, you guys, all this is called the body of the stomach. This area right by the esophagus is called the cardia. You can imagine why. It's right by the heart. And then this region down here by the duodenum is called the pyloric region, right? Or the pylorus. So the reason why this is called the pyloric region is that this sphincter here is called the pyloric sphincter. So the pyloric sphincter is a strong muscle that separates your stomach from the small intestine. And you can imagine how that would be significant, because you wouldn't want just stomach contents entering the small intestine right away. We'll talk about why that's a bad thing and how that leads to problems. But for now, just think about the pyloric sphincter as sort of forming a nice barrier between the stomach and the small intestine. That way you can release things in a coordinated manner. They don't just get shoved through right away, right? Because first of all, you're going to want digestive enzymes and acid in your stomach to start to break down that bolus of food before it continues on. So you're going to have to compartmentalize digestion here. And so the pyloric sphincter compartmentalizes the stomach versus the small intestine. Okay. So if you guys look in the wall of the stomach, we got three muscular layers here. We have a longitudinal layer, a circular layer, and an oblique layer. If you guys remember going back to that one slide where we looked at the gut tube, a typical gut tube. A typical gut tube only has two layers. We had a longitudinal layer and a circular layer. The stomach is special because it has a third extra layer, and it's an oblique layer. And the reason why they're named this way, you guys, is that the direction of their fibers goes in different angles, right? So you can see longitudinal goes this way, circular kind of wraps around it as well, and then oblique goes sort of at an angle, right? An oblique angle. So these three together allow the stomach to have some really interesting motions and movement, right? So if you guys remember, there's two types of digestion. We had chemical and mechanical digestion. And both of those occur in the stomach. Mechanically, you can use the smooth muscle layers here to really start mixing around that food and start breaking it apart into smaller pieces, okay? Now, if you look inside the stomach, see how it's kind of swirly here? Those swirls are called the rugae. And rugae are basically these folds within the wall of the stomach. And can you guys imagine what this could be for? Like, why would you want to have all these circular folds inside of your stomach? What if it were smooth and you tried to mix food? What would happen? It would just kind of slide around and slosh around in there. So one of the function of rugae is to kind of grab onto that food, right? Because it forms some nice little kind of gripping action, and it can help grab onto it and mix it even better. And you can actually stretch your stomach, right? So if you think about, well, when the stomach stretches, what's actually stretching? Well, the rugae are kind of, stretching out. So the rugae help have some surface area that allow for the stomach to stretch, more than it would be in its resting state. Now, if you eat a lot of food, like a significant amount in each sitting, your stomach can just stretch anatomically. It can get bigger over time, and I've seen this personally, like with cadaver dissections. And the same is true, or opposite too, you guys. Let's say if you don't eat as much, like if you're on a feeding tube or you're just on very, very small meals, over the course of the day, your stomach can also shrink, which is interesting. So, but you do find that the rugae help for the stomach to stretch. Okay, so if we look at the stomach and where it's anchored, first of all, what's this curvature here called? Lesser curvature, and this one? Greater curvature. And you guys see this yellow material? That's the lesser omentum, right? So the lesser omentum helps anchor the lesser curvature of the stomach to the liver. And then over here, it's cut, but all of this would be greater omentum, right? And you can imagine that all this greater omentum would continue down over the anterior surface of all of these abdominal organs right here, right? That's greater omentum. And so again, it's going to help hold the stomach in place. So we talked earlier that yes, the stomach helps with some churning action, but it also can't tie itself in knots or twist around because it's actually anchored in place by your omentum, right? And that happens to be made of serous membrane, so it lubricates as well. Does that make sense, you guys? Cool. Okay, so now we're going to do is move on to talk about microscopic anatomy of the stomach. Now the stomach has all of those layers we talked about earlier. It's got the mucosa, it's got submucosa, it's got a muscularis and a serosa, right? If you guys remember that in that order. However, the mucosa of the stomach is more modified and it's different than other areas of your digestive tract or alimentary canal. So if you all remember, the mucosa is the layer that lines the inside and it's kind of right by the lumen, right? It's called a mucosa because you have a nice mucus layer there. So you can imagine that there's going to be lots of mucus cells in the stomach wall that make a nice protective layer of mucus there. And they secrete a 2-layer coat of alkaline mucus. That actually makes a lot of sense, right? Because if your stomach acid is a pH of 1, you want to have a mucus that's kind of basic. That way it forms a nice protective barrier there, right? So if you're wearing like a jacket today because it's kind of a little colder out this morning, think of your jacket as like the mucus layer for your body, and it protects your body from like the harmful outside environment. So what you also find in the mucosa, it's dotted with these things called gastric pits. So if you looked at the mucosa of the stomach, and this would be microscopic, but under a microscope, you can see there are all these little holes in the mucosa of the stomach. Now, those are called gastric pits. And the gastric pits are kind of like little canals. So they go deep into the mucosa, right? Now, those gastric pits lead into these gastric glands, which are even deeper in the mucosa. And those gastric glands have specialized cells that secrete acid and enzymes, okay? So these gastric glands are the things that contribute to what we call gastric juice, right? And that's got to be really acidic. So if we look at the histology here, this would be our lumen, which would be the inside of the stomach. Here are these gastric pits, and to me they're almost like mine shafts, like mine tunnels. You know, you look down here, and all of a sudden you can go really deep into that mine shaft, right? And you keep going down, 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 and eventually it leads into these gastric glands. So all of this right here is the gastric gland, right? These are the gastric pits. But if you guys look at these cells, they're differently colored than these cells. The reason being is that these cells here are the epithelial cells that line sort of the lumen of your stomach, right? And it's a simple columnar epithelium if you look closely. But dotted within that simple columnar epithelium, you also find something called mucus neck cells. And these mucus neck cells secrete that alkaline mucus that protects the inside of the stomach, right? So if you look down here in the gastric glands, we have 3 major cell types. We have parietal cells, chief cells, and these enteroendocrine G cells, okay? So parietal cells mainly secrete hydrochloric acid, right? So you guys have worked with hydrochloric acid at some point in your lives. You can buy it actually at Home Depot or Lowe's or whatever. They call it muriatic acid in the department store, but it's effectively hydrochloric acid. That's what your body can make and secrete into the stomach lumen to digest those materials. Now the chief cells here, those ones actually secrete enzyme, it's one called pepsinogen. Pepsinogen is actually activated by hydrochloric acid into something called pepsin, and pepsin is a protease, which means it breaks down protein, right? It chops it up into smaller bits. And then we have these enteroendocrine cells. What do you guys think they do based on the name? Enteroendocrine. What do you think they release? Hormones, exactly, right. So enteroendocrine cells release hormones. The major hormone that these enteroendocrine cells release, you guys, is one called gastrin, right? So gastrin is a hormone that we'll talk about here in a minute. So if we zoom in on these gastric glands, by the way, what will be up here? What should be up here? If this is the gastric gland, what would be kind of higher up here? The pit, right? And then what would be even above the pit? the space of your stomach, right, or the lumen. No problem. So if you guys look closely here, we have parietal cells, and those secrete hydrochloric acid, right? Now, hydrochloric acid here, released by these parietal cells, it activates the pepsinogen that's released by your chief cells, okay? Now, if you guys see this, so if you see a word in biology that says pepsinogen, or just it ends with ogen rather, okay? That's the inactive form of an enzyme, okay? So if it's pepsinogen, it's not able to digest yet. But when hydrochloric acid comes in and cuts off a piece of that protein, or cleaves it, what happens is it converts it into another enzyme called pepsin, okay? Pepsin is a protease, which means it breaks down protein. Now what pepsin can do too is actually convert pepsinogen into more pepsin. So once you get a little bit of pepsin to form, it can go back and convert pepsinogen into further pepsin. And so that's a type of positive feedback because it's essentially sort of increasing the number of something, right? Or the amount of pepsin. And so what you're going to do is really ramp up digestion. You guys are going to see this here. There's this general tendency for once you begin the process of digestion, it really ramps up fast. And it's typically through positive feedback mechanisms, like the conversion of pepsinogen into pepsin, how it can go back and reconvert itself. Okay. Now, gastric gland secretions are going to be pretty acidic, right? And they're acidic because of the parietal cell secretions of hydrochloric acid. You know, when you think about the pH of your stomach, it can vary anywhere between like pH of 1.5 to 3.5. But we also have chemoreceptors inside of our stomach that prevent the pH from getting too low. So once it's too acidic inside your stomach, you stop making additional acid. And that makes sense because you wouldn't want to have it be so acidic that it burns a hole through your stomach wall. And that could potentially happen. Now, hydrochloric acid here, you guys, or HCl, is the acid. Now, it's really what makes this an acid is this hydrogen atom, right? So we call that a proton. And the hydrogen proton here is the acidic portion of hydrochloric acid. The chloride atom here, that one's just part of the ionic bond that hydrochloric acid is. Now, what's interesting then is you might wonder, well, why would you want your stomach to be so acidic? Well, what that does is, first of all, is it denatures protein, right? So it causes the protein that you ingest to start to unfold. Because if you all remember going back to A&P 1 or even previous classes, we learned that proteins, when they form, they actually can form into like three-dimensional shapes, right? And what holds those proteins together in a three-dimensional shape are hydrogen bonds. Hydrogen bonds can be broken with acid. So if you start breaking those hydrogen bonds, the proteins start to denature and they kind of fall apart and they get more loose. And now if it's looser and kind of fall apart, it's easier to digest. That way pepsin can come in and start chopping up that protein into smaller bits, which actually makes a lot of sense. Now, it also activates pepsin, which we talked about. So hydrochloric acid activates pepsinogen into pepsin. Okay, it helps break down plant cell walls, and that's important too, you guys. If you're eating vegetables, the wall of the vegetable is cellulose, right? The cell wall. Now, we actually don't have the enzyme. Humans don't make cellulase to break down plant cell walls, which means we have to rely on things like stomach acid to break apart the plant cell wall to get the cell to open up. That way we can get the nutrients out from the cytoplasm of that cell, right? But humans don't make cellulase to break down plant cell walls. It also kills bacteria. If you ever wondered, like, well, you can kind of eat somewhat spoiled food. I'll give you an example. Have you guys ever eaten bread and it's just slightly moldy? Like you see there's just a little mold on there, you're like, all right, whatever, it's not too bad. You don't have to admit to it. I have, for sure, you guys. I've been that hungry before. Now, you might wonder, okay, well, if it's slightly moldy, like how did you not get like an infection of your gut? Well, for one, that bacteria that's on bread, or mold rather, it might not be the type that likes to live in that environment. Like if it's not acid tolerant, your acid can break it down or just essentially make it a less hospitable environment, right? And there are some animals that have super acidic stomachs. One example, vultures. Think about it. Like vultures can eat roadkill on the side of the road, and it might have been like baking in a hot sun for the last couple days. And they can just go over there and they start picking at it. They take off little bits of it, And they can eat that rotten food, no problem. You're thinking, how the heck do vultures not get food poisoning, right? Well, they have super acidic stomachs. Now, ours aren't as acidic as a vulture's stomach, but we can still kill off a lot of bacteria with the stomach acid, which is good. Okay. Now, the parietal cells of your gastric glands also secrete something called intrinsic factor. Intrinsic factor is a glycoprotein, right? So it's a sugary protein. And the function of this glycoprotein is it actually binds to vitamin B12 in your stomach, and you need intrinsic factor to absorb vitamin B12 into your body. And so one thing you'll find, and vitamin B12 is necessary for proper nerve function. It's necessary for proper metabolism. So if you don't make enough intrinsic factor in your stomach, you won't absorb vitamin B12, which means you can start to get neuropathy or nerve dysfunction. And that's one of the things you see with chronic alcoholism, where because alcoholics are drinking liquor all the time or whatever, maybe it's wine coolers, maybe you're addicted to wine coolers. And so let's say you're just like throwing back wine coolers, constantly. Well, there's still alcohol in those wine coolers, albeit not a lot, right? You might just like the taste. So what that could do, though, is start to irritate the lining of your stomach, because alcohol is an irritant, right? Now, if you irritate the stomach lining so much that it can't produce intrinsic factor, over time, you'll find that people who are alcoholics stop being able to absorb vitamin B12, which means they get nervous system dysfunction. And there's one called Korsakov's dementia, where it's a dementia that's associated with the vitamin B12 deficiency that's caused by alcoholism. But you need enough. I don't think it's kind of funny. It's like Korsakov, like it sounds Russian, it seems somewhat appropriate. Just throwing back shots of vodka a lot. Anyways, this glycoprotein is involved with the absorption of vitamin B12. So that comes from parietal cells. Don't forget that. All right. So the chief cells secrete pepsinogen. Now, is this active yet? Pepsinogen? No. So what does activate pepsinogen into pepsin? Hydrochloric acid or pepsin itself, right? So you need hydrochloric acid or the existence of pepsin already to activate pepsinogen into pepsin, right? And so it's a positive feedback loop, if that makes sense. That's a protease, right? And so it's activated by hydrochloric acid or pepsin, and it's a positive feedback mechanism because pepsin can convert pepsinogen into more pepsin and back and forth, right? So it's sort of a self-serving loop. Now, the function of this pepsin here is to break down protein, right? So already in your stomach, you're starting to cleave polypeptide into smaller sequences of amino acids. And you might even get some individual amino acids in here too, right? Where you can break them off the polypeptide. Now you just have loose amino acids that are now in their absorbable form. The whole purpose of digestion here, you guys, is you want to break apart what you eat into smaller pieces. That way you're actually able to absorb it, right? Like you can't just absorb like a hamburger bun in its whole state across your digestive wall, although that would be kind of cool. So lipases digest lipids, which makes sense, right? And so what's kind of cool is in your stomach, 15% of your lipids are already digested there, okay? So what about these enteroendocrine cells? Well, another word for these ones in the stomach, guys, we call them G cells, right? And it's not because they're gangster. It's because they release a hormone called gastrin. So these enteroendocrine G cells release a hormone, gastrin. They can also release histamine and serotonin. We actually won't get into the histamine and serotonin mechanisms here, okay? We're just going to focus on gastrin because gastrin plays a more systemic role in coordinating digestion. But what's kind of cool, though, is gastrin, released by these enteroendocrine G cells, it actually excites gastric gland cells to keep making more of their secretion, right? And it does this through stimulation by the vagus nerve or by sensing the pH of your stomach, right? And so if your pH of your stomach is higher because you ingested food or because your vagus nerve is stimulating these cells, they pump out the hormone gastrin, which goes throughout your body, and it acts on your stomach to cause your stomach to start having more muscular contractions and secreting acid and enzymes. So it kind of makes sense. Again, you guys remember, we're kind of ramping up digestion here. So it's sort of positive feedback in that regard. So in terms of the regulation of gastric secretion, it occurs in three major phases, right? We got the cephalic phase, the gastric phase, and the intestinal phase. When you guys think cephalic, if you remember, that's pertaining to the head, right? So the cephalic phase would be the phase of gastric secretion that's caused by you just thinking about food or seeing it or smelling it, right? Or maybe hearing it being made or something, you know? So the cephalic phase is before you've actually even ingested food. You just kind of have this idea like food is coming, like it's impending. So that what happens here is that your brain, via your vagus nerve, begins to coordinate sort of what we call feed forward, which is the preparation for a future event, right? And so cephalic phase is a reflex, but it's conditioned by like the thought, the sight, the taste, the smell, or the sound of food or whatever. All right. So the gastric phase, though, is when food actually enters the stomach, right? Then you begin your gastric phase. Now the gastric phase lasts for several hours after you eat. And the reason being is it takes that much time for food to continue on from the stomach to the small intestine. But as long as there's food present in the stomach, we're going to be in the gastric phase in some regard, okay? Now what happens is once that food enters the stomach, it changes the pH of your stomach juices, right? So the food you eat is typically not as acidic as a pH of 1, right? It's going to be a little bit higher pH. So when you ingest that food, your pH of your stomach rises. There's cells, chemoreceptive cells in your stomach that can sense that, and that's when you would begin the gastric phase, okay? So it's stimulated by distension, peptides, low acidity, right? It means more basic or higher pH, or gastrin. But gastrin is the major stimulus, right? So remember, gastric is stimulated by the vagus nerve, but it's also stimulated by a rise in pH, okay? Now, what happens with the gastric phase, you guys, is that through the release of gastrin as a hormone, what did gastrin act on? It's actually even in the name of the hormone, right? So gastrin hormone acts on the stomach, right? Because gastric stomach. So gastrin hormone acts on the stomach. But what does gastrin do to the stomach? Does it excite it or inhibit it? It excites it, right? So what gastrin does here after it's released by the stomach is it starts to really stimulate stomach activities, right? So the churning and the releasing of more acid and enzymes in your stomach. Then we have something called the intestinal phase. The intestinal phase begins when partially digested stomach contents, which we call chyme, enter the small intestine. And what happens in the intestinal phase, you guys, is you actually inhibit the stomach temporarily. So you prevent the stomach from secreting more acid and enzymes, and it slows down those muscular waves, and it gives your small intestine time to really digest and process that material to be absorbed into your small intestine, right? So it's kind of like this. You start thinking about, number one here, cephalic reflex phase. You start thinking about food, your stomach starts to secrete a lot of juices to prepare for that, right? Then the food enters your stomach, and you start to digest it by churning it around and mixing it with stomach acid, right? And that's mediated by the release of hormone. And then what happens is your stomach kind of forces some of that food into the small intestine. And once that chyme enters the small intestine or duodenum, what happens is then you enter the intestinal phase, number 3, and then the duodenum actually releases hormones that inhibit your stomach. And the purpose of that is you've got to give the small intestine time to digest. If you don't, then it's going to occur too quickly. And you're actually going to have undigested material moving along your digestive tract. So it's got to be fast, but also not too fast. And that's why we have some sort of mechanisms to slow it down, and that would be the intestinal phase, which we'll talk about in more detail. So if y'all remember, the gastric phase was stimulated by, for one, gastrin. Remember, gastrin was stimulated by the release of vagus nerve stimulation on your stomach. Now what gastrin does is it actually acts on the parietal cells to release more hydrochloric acid, as well as the chief cells to release more pepsinogen, and ultimately just make more gastric juice, right? So gastrin stimulates the release of gastric juice. We see a rise in pH because of the buffering action of ingested proteins. That also stimulates gastrin secretion. So remember, gastrin is sensitive, the release of gastrin is sensitive to a change in pH of your stomach. And then there's also some chemicals here too, guys, like acetylcholine and histamine that can stimulate parietal cells through what are called second messenger systems. Now this is important to note because if you're taking things like antihistamines, or if you're taking drugs that affect the acetylcholinergic system, what's going to happen then is you might also get problems with digestion, right? So you might get some, undigested material sitting in your stomach longer, if that makes sense. So all three of these, though, are necessary for maximum hydrochloric acid secretion. All right, so how do our stomachs make acid? That's kind of weird, right? To think about how a part of your body can make acid, and it's so acidic, it can burn itself, right? That's kind of really funky to think about. It almost sounds like Alien, Remember that movie where they can spit at? Or no, actually their blood was acidic, right? You guys ever see that? In the movie Alien, like one of their the arm would get cut off or something, and their blood was so acidic it would burn holes through the metal of the spaceship. What's that? Yeah, it was neon green, exactly. Now, this type of acid, you guys, it could potentially burn a hole through your stomach, and you've heard of this with gastric ulcers, right? And there's actually different degrees of ulcers. You can have a penetrating ulcer that goes through the entirety of the wall of your stomach. That way, you actually now have a hole opening up into the abdominal cavity inside your stomach. Now, what normally protects against that, though, was a nice little mucus layer here, right, in the lumen of your stomach. Now, in the wall, though, of the stomach itself, you have cells like your chief cells and your parietal cells. Now, the parietal cells are identifiable because they have this sort of brush border here with lots of wavy apical membrane. Okay. Now, what happens here, though, you guys, is we can take carbon dioxide, right? So take carbon dioxide from the solutions of your body, and either spontaneously or non-spontaneously, randomly or enzymatically, carbon dioxide and water turn into something called carbonic acid, which is H2CO3. Okay? Now, this is a type of acid that would naturally build up in your body as carbon dioxide levels also build up. That's just true of carbon dioxide in water. It can turn into an acid. Okay? Now, you can do this through an enzyme called carbonic anhydrase. So enzymes can speed up the conversion of CO2 in water, right, into carbonic acid, or it can actually happen spontaneously as well. Now, what's pretty cool, though, is that this carbonic acid can dissociate or break into two. It breaks into a bicarbonate ion, HCO3O-, which is basically what baking soda is, okay? And it can also break into this hydrogen ion. So which one's the acid, you guys? Is it the hydrogen ion or the bicarbonate ion? The hydrogen ion, you got it, right? So then now we have loose hydrogen ion inside of our parietal cells. What these parietal cells can do is use something called this proton pump. It's a hydrogen potassium ATPase. And what this does is it uses the chemical energy in ATP to essentially pump hydrogen ions out into the stomach lumen and potassium ions back into the parietal cell. Okay? You might wonder, well, why would you want to do that? Why would you want to pump one ion out and another ion in? Well, look at their charge, you guys. Do y'all see this? So they're both positive. What would happen if you only just kept pumping a tremendous amount of positive charge outside of the cell is you would mess up the charge balance across that membrane. So you'd change the voltage. And that would also change how you're able to get nutrients in and out of the cell, right? Or just molecules in general if they have a charge. So to maintain a normal charge balance, what you got to do is not only just pump out one positively charged ion or cation, but also pump another one back in, okay? Now, these can leak out as well. There's leakage channels for potassium, but this helps maintain the charge balance. Now, chloride ions also get pulled out through a leakage channel. But you guys look here, the chloride ion is negatively charged. Our hydrogen ion's positively charged, so those actually attract. So what happens is as you start pumping out protons using this proton pump, right, chloride ions can leak out in the direction of those positive charges. That way they make hydrochloric acid. Now, this doesn't happen just right away. It takes time to really pump out enough hydrogen ions to even make an acidic solution outside of the cell. But ultimately, it comes from carbon dioxide in the blood. So what do you guys think happens to the pH of your blood if you're taking carbon dioxide out of it and using that to make acid, which is then secreted into your stomach? Right? Remember, carbon dioxide in water makes an acid. So if you're removing carbon dioxide from the watery part of your blood, what happens to your blood pH? It becomes more basic. You got it. In fact, it's not shown. Actually, it kind of is right here. Do you guys see this? We call it the alkaline tide. So after you eat a meal and you start to secrete a tremendous amount of stomach acid, your blood pH is measurably more basic than at rest. That's what we call this alkaline tide. Okay, so it's temporarily becomes more basic. Now, it can restore back to a normal state because you can reabsorb those hydrogen ions back in your body, right, when you're done. But what if you actually end up vomiting up all that stomach acid? Well, you're losing it from your body, right? And so that's a type that can lead to a condition called metabolic alkalosis, right? And so metabolic alkalosis is through the excessive loss of acid, and that can happen like with excessive vomiting. So people who like are vomiting a lot for whatever reason, they can actually have very, very basic blood, and that can become life-threatening too if it becomes too alkaline, okay, through the loss of too much acid. All right, cool, guys. So let's move on to the intestinal phase. So remember, in the gastric phase, you release gastrin. Gastrin excites the stomach to release more juices, right? Now, during the intestinal phase, there's two major parts. We have a stimulatory and an inhibitory component to this gastric phase. The stimulatory component is where you have partially digested food that enters the duodenum, and that temporarily leads to a kind of a brief influx of gastrin in the bloodstream. What does gastrin do to the stomach? It excites it, right? So that's going to cause the stomach to cause more contraction, right? So it's going to contract more chyme into the duodenum, and you're going to release some gastrin. That's only the first part, though, because once enough chyme enters the duodenum, then you enter this inhibitory component, right? And so the inhibitory phase is this what we call enterogastric reflex, where once enough acidic chyme, partially digested fat, and protein enters the duodenum releases hormones like secrete and cholecystokinin and gastric inhibitory peptide, or GIP. Now, what these hormones do from your duodenum is they actually inhibit the stomach from secreting more acid, and they inhibit the stomach from contracting and moving that chyme into the duodenum, right? And so that's why you have this inhibition here. Now, these reflexes are mediated by vagal nuclei in your medulla. There's also local reflexes, and we have sympathetic nerve fibers that help to tighten up that pyloric sphincter as well. Now, the function of this inhibitory component here, you guys, is that you want to decrease gastric activity, first of all, so you don't secrete too much stomach acid, right? Secondly, you don't want the stomach to force contents into the duodenum too quickly, because if it did, first of all, that's a lot of acid. The duodenum is not adapted to acid, okay? It's also a lot to really handle at once. You know, and you guys do this naturally, like you take bites of food, right? But imagine like if all of a sudden something was forcing big old bites in your mouth, right? It'd be almost impossible to chew that up and digest it. Think about that with your duodenum. If your duodenum is receiving things from your stomach, it can only get small little pieces at a time. If you started getting gigantic quantities of food or chyme from your stomach, the duodenum couldn't handle it, right? And so you actually would get partially undigested material in your feces at that point. So you're losing nutrients, which wouldn't be very effective, okay? So what this is showing you guys is what the stomach does to move material around. So we have propulsion, which is where contents are moved towards the pyloric sphincter. We have grinding, which is essentially where the muscle starts to kind of have like a waving motion, okay? And then we also have what's called retropulsion, where the stomach is able to contract in a way that forces material back and forward at the same time, because essentially you're contracting just this area here. So some material is forced backward. In fact, it can kind of make some bubbles. That way, that's kind of why you burp sometimes while you're digesting. But it also forces some material here into the duodenum. But the pyloric sphincter also has to relax slightly to allow material to pass, right? So what happens when this partially digested chyme enters the duodenum? Do you guys remember? What happens next? So partially digested chyme enters the duodenum. What's the next step? Do you know? You're not going to look it up? Just going to stare at me? You guys tell me, what's the next step? That's good. So nutrients begin to be absorbed in the duodenum, but what else? We just talked about this a lot. Like, yeah, you get the release of gastrin, good, from the duodenum, and then gastrin on the stomach causes more of this retropulsion, so you get even more chyme, but that can't continue, right? So that's the first step, which is the excitatory phase. And then what's the second step? Once you get enough chyme in the duodenum? Inhibitory phase. Nice, good. And it's the substances in that chyme that are inhibitory, right? So we talked about like the fact that it's acidic, or the fact that you have partially digested protein and lipids in the duodenum. You have chemoreceptors for that material, and that causes the release of hormone by your duodenum that inhibits the stomach from doing this further, right? And that phase we call the intestinal phase. So this one's just showing phases of the gastric phase, right? But once you get enough chyme in the duodenum, then we start to enter that intestinal phase, which is actually mostly an inhibitory phase on the stomach itself. So as chyme enters the duodenum, receptors respond to stretch and chemicals. You get that excitatory phase temporarily with the release of gastrin, but then as the duodenum begins to fill up with carbohydrate-rich chyme or lipid-rich chyme, then you inhibit the stomach from releasing more chyme into the duodenum, right? So it's got to slow it down. Now, there's a difference, though, in terms of how certain nutrients are treated. So carbohydrates are digested more quickly. Lipids are digested more slowly. So what happens is that you spend less time in the intestinal phase if you have a carbohydrate-rich meal. Like, let's say if you decided to eat like just a huge loaf of bread for dinner. Why not? You're like, all right, that sounds good to me. Okay, that's basically mostly carbohydrates, right? You're gonna digest that pretty dang quickly. In fact, you're gonna feel fuller sooner because of that. Okay. Now, lipids are actually treated a little more differently, right? So when the chyme is fatty, you spend less time in the intestinal phase and a lot of time in the gastric phase, where you're just basically trying to digest those lipids. You're trying to digest that fat and give it time to fully begin to break down into free fatty acids. Okay. Now, fatty chyme can remain in your stomach or duodenum as well for up to 6 hours. So you're going to feel fuller longer with like a fatty meal. Now, it's not good to like ingest a tremendous amount of fat, right? But what's interesting though, for people with eating disorders, they will typically eat fat-rich food, but not a lot of it, because they can eat just a little bit of fatty food, and it makes them feel fuller longer. That way, they can effectively starve themselves, you know. And so, one thing that people will do sometimes if they have an eating disorder is they'll just eat like a little bit of cheese as their meal. Like for lunch, they'll have just like a little cube of cheese or something, right? Because cheese can be up to 70% fat. It's mostly fat. And you know, if you're just eating that, you're going to feel fuller longer because it stays there longer, if that makes sense. Okay, so it's something to keep an eye out for. Okay, so with this intestinal phase, you guys, we get the release of what are called enterogastrones, and they're basically hormones that are released by your duodenum here. Now, there's 3 major ones here. We have secretin, cholecystokinin, or CCK, and then vasoactive intestinal peptide, or VIP, aka gastric inhibitory peptide, or GIP, and all of these inhibit gastric secretion. And that actually makes a lot of sense because you want the stomach to slow down. That way the duodenum has time to digest. So if the small intestine is pushed, it accepts more chyme, you end up with something called dumping syndrome. You guys heard this before? So dumping syndrome is where your duodenum receives too much partially digested chyme, right, at once. First of all, what that does is it burns your duodenum. Because remember, the duodenum is not adapted for acidic chyme like your stomach is. Okay. Secondly, you absorb nutrients too quickly. So imagine you did eat a lot of bread, right? And you got a big old belly full of bread now because you decided I'm gonna kill this loaf of bread for dinner. You know, I've done that before. I'm not gonna lie. like freshly baked bread. Oh my gosh, it's awesome. So and you realize, oh dang, I ate the whole thing. Oh well. Okay, so you eat a lot of bread, right? Let's say if it gets pushed into your duodenum too quickly. What can happen then is you get rapid absorption of sugar, okay? What hormone do you release when your blood sugar levels rise? Insulin. So then your insulin levels rise. But then if your insulin levels spike, what happens to your blood sugar as a result? It crashes, right? So your blood sugar starts to crash, and it crashes fast So what happens with dumping syndrome is you get what's called rebound hypoglycemia because of this rapid increase of nutrients. You get a rapid release of insulin. Then all of a sudden your blood sugar levels crash. And they crash so fast that you start to not only get sleepy, you get nauseous, right? And so that nausea is associated with dumping syndrome. That's where you absorb the nutrients too quickly. And you get rebound hypoglycemia from insulin. Now this is a problem in people who've had gastric bypass surgery, right? Because if their stomach can't hold as much material, but they're still trying to eat the same quantity of food, they're effectively forcing that food into their duodenum too quickly. And so what have you guys heard about the dietary needs of someone who has had gastric bypass? Like, how do they eat? You got it. Many small meals throughout the day. Like, maybe we're all supposed to do 3 large meals a day or so. That's not what I do, but that's kind of what people do. You know, we have names for them. Breakfast, lunch, and dinner, right? Now, if your stomach is smaller and it can't accept that much material, then you have to eat smaller quantities over the course of the whole day because you can't store them, right? And if you don't, you can end up with dumping syndrome where the material enters your duodenum too quickly. So it's kind of interesting. Now, so you see this a lot with gastric bypass. All right, guys, cool. So vomiting or emesis is caused by extreme stretching. Have you guys had that before? Maybe like have you eaten so much that it's actually made you vomit before? I have. Not good. I went to a party a couple years ago. I had too many burgers, and I don't know. I just was like, I don't know if I was just like starving or something, but I ate so many hamburgers, you guys, that by the time I got home, I was in so much pain. I'm like, I just have to vomit because like I felt like my stomach was going to tear open. You know what I mean? And I haven't done that in a while, but it's not good. It's like binge eating, right? So extreme stretching can lead to emesis. That makes sense. The stomach kind of protects itself. Okay. Irritants, right? Chemical irritants, whether it's like alcohol, excessive acid, or spicy food, that kind of stuff. You know, that can make you want to vomit. Certain bacterial toxins can also trigger emesis, and certain drugs as well. Now, what happens, you guys, is we actually have an emetic center of our medulla. And this is a place where it receives impulses from nerves that serve the stomach, like your vagus nerve. There's also an emetic center of your hypothalamus, and that's a place where the blood-brain barrier is very thin. So instead of being a tight blood-brain barrier, it's thin, because let's say if you did absorb some of these bacterial toxins in your bloodstream, by the time they get to your brain can kind of pick up that information, and that in itself can trigger a vomiting reflex too. So it does involve actually direct chemical sensory mechanisms of your brain. Now, excessive vomiting can lead to, first of all, dehydration. That makes sense. Electrolyte imbalance, because you're losing excess potassium or chloride, or whatever you're also trying to ingest, as well as metabolic alkalosis. You guys remember that one? Because if you guys remember, if you're losing that acid out of your body from vomiting, you're not able to reabsorb it. And so then it's gone forever. And that's going to keep your blood alkaline. Remember the alkaline tide after you ingest, right? And so this alkalosis can be life-threatening, but it's got to be a pH like above 7.8, which is pretty dang high. Like your normal blood pH is 7.35 to 7.45. So you'd have to have a lot of vomiting and a lot of loss of acid to get to a life-threatening level of alkalosis. You're going to get a lot of interesting signs and symptoms before that, but we'll talk about that in pathophysiology. So if we can summarize these events, you guys, remember there were 3 major phases of gastric secretion. We had the cephalic phase, the gastric phase, and the intestinal phase, right? Now we can divide this in terms of stimulatory events and inhibitory events, okay? So the stimulatory events are all of these down here, and you can see that there's stimulatory events in the cephalic phase, the gastric phase, and the intestinal phase. And then we also have inhibitory events within each of those too. So let's just focus on the stimulatory events for now. So you might wonder, well, what are the stimulatory events of the cephalic phase? Well, remember, cephalic meant thought, like the brain, right? So the sight and thought of food causes your cerebral cortex through a conditioned reflex to act on your hypothalamus and medulla oblongata to mediate excitatory input through what's called the vagus nerve. Remember cranial nerve number 10? It goes down your neck, down towards your thoracic and abdominal viscera. So your vagus nerve can actually be, it's under unconscious control, but through conditioning, you can stimulate the vagus nerve, right? Okay, so stimulation of taste and smell receptors. You know, you might actually smell or taste a little bit of food, and that also can activate this vagus nerve that also activates your stomach. So that makes sense. They're both stimulatory events of the cephalic phase. If it's cephalic phase, has food entered your stomach yet? No. You're still either just tasting it or smelling it or just thinking about it, right? Okay. So what about this gastric phase? Well, the gastric phase begins once food enters the stomach. So now you can think about, well, what are the stimulatory events of the stomach? Well, it has to be something that involves the presence of food, right? So there's two major factors here. We have distension and chemoreceptors. So distension of the stomach would be baroreceptors that can measure the stretch of your stomach, right? So once you activate these stretch receptors, you get vasovagal and local reflexes that stimulate muscle contractions to begin, as well as the creation of gastric juices, okay? Now, we also have chemoreceptors in the stomach lining that can sense the presence of like partially digested lipids and protein, and also a change in pH. Now, what happens then is that the G cells here release gastrin into the bloodstream, and then gastrin, remember, causes the stomach to increase its activities. So that makes sense, that both of these mechanisms are based on the presence of food in the stomach. And then what about the intestinal phase, you guys? When does the intestinal phase begin? Once food enters the duodenum. Yeah, the beginning of the small intestine, which is the duodenum. Good. So once this food enters the duodenum, and you have chemoreceptors there, the presence of partially digested material causes a temporarily increase in gastrin, right? So you get a temporary rise in gastrin. It's a very brief effect, and the effect of this is just to get a little bit more chyme, right? It's almost like the duodenum can sense the chyme is there, and so then it temporarily causes more chyme to come. But then it stops, right? So the inhibitory effect of this on this side here is that distension and chemoreceptors within the duodenum lead to reflexes that ultimately inhibit the stomach. So really most of the intestinal phase, you guys, is an inhibitory phase of the stomach because you don't want material to enter the duodenum too quickly. If it does, you get dumping syndrome. All right, cool. So another thing that can happen too, guys, in terms of your gastric phase is that if you're emotionally stressed, that can prevent you from wanting to digest because you're just more sympathetically active. That's just more fight or flight. So if you're just stressed in general, you can't. It depends on how people deal with stress, but sometimes people will avoid eating when they're stressed. So that's why you see a lot of weight loss, right? Like I lost probably 20 pounds before I got married. It's just stressful. And I don't know where it came from because I'm already really skinny. Anyways, what was I trying to say? Oh yeah. That emotional stress can prevent your stomach from digesting, right? So you also feel less hungry as a result too. Now, we also know that the stomach protects itself, and it protects itself because if the pH of your stomach gets below 2 or below closer to 1, then it starts to prevent the additional release of acid through local reflexes, right? That way your stomach juices don't get too acidic and you don't burn a hole in your stomach wall, which makes a lot of sense. And then in terms of the cephalic phase, you guys, loss of appetite or depression, right? There's lots of things that can cause you to lose your appetite. We can go down that list, but you guys have all felt that at some point in your lives where you've lost your appetite for some reason. Maybe you saw something or smelled something that was unappealing, or maybe the food tasted bad or just kind of wrong. You're like, oh, I can't eat this, or depression in itself can also prevent you from feeling hungry so that you don't enter the cephalic phase and you don't seek out food. So it's kind of interesting. So we kind of touched on all of these already, right, throughout the course of these slides. So remember, let's summarize this, guys. The 3 phases of gastric activity. What do we got? Cephalic, gastric, intestinal. What stimulates the cephalic phase, just to kind of summarize this? Well, the vagus nerve kind of carries the information to your stomach, right? But what gets the cephalic phase started? Thought, right. Just thinking about food, right? You're thinking, oh, I'm feeling kind of hungry. I can really go for a donut right now, right? Or some coffee or whatever, right? Just thinking about it. That, being by the vagus nerve, good, stimulates your stomach to start releasing juices. Okay, gastric juices. We talked about that already. What about the gastric phase? When does that begin? When food actually enters the stomach. Good. Okay. Now, how does your stomach know that food is there? Baroreceptors for stretch. Nice. Chemoreceptors are also there, and those can pick up information like change in pH. That's the major one. Okay. Now, if you're eating food and food enters your stomach, is your pH your stomach going to get more acidic or more basic once you eat and it's swallowed that food? More basic, right? More alkaline. So once those chemoreceptors pick up that your stomach acid is more alkaline, that also stimulates the stomach to start, through local reflexes, to start making more acid and churning. Okay, good. What begins the intestinal phase? Good. When food enters the duodenum. Now, I've been using this word, and maybe I should define it better. There's a word called chyme, remember? So chyme was the mixture of stomach acid and food in your stomach, right? And when it enters the duodenum, we call that chyme. So it's like partially digested material. So at this point, we call it chyme, right? And so when chyme enters the duodenum, what's the first thing that happens? Gastrin release. From the intestine, though. That's kind of weird, right? Not the stomach. So there's also an intestinal gastrin. And that temporary rise in gastrin does what to the stomach? Excites it, right? Temporarily, very briefly. And what does that do in terms of chyme in the duodenum? It gives a little push, right? Just a tiny little more push. Just a little bit more. Just, right? A little more chyme in there. And then what? Stop, right? You stop it. Then you enter the inhibitory intestinal phase, right? And that's from distension and the presence of too much acid there, right? And what that does then is through local reflexes inhibits the release of additional stomach acid and churning by your stomach, but it's also mediated by hormones called the enterogastrones, like cholecystokinin, gastric inhibitory peptide, also called vasoactive intestinal peptide, and secretin. All those hormones that are released by your duodenum also inhibit the stomach, right? So you have inhibitory hormones there too, all right? Good. And then what about during the gastric phase? What can prevent your stomach from being excessively active? Good, like too acidic. Like if your stomach becomes too acidic, then it basically shuts off. Like, oh, got enough, don't need any more, right? So it's negative feedback there. And emotional disturbances can play a role too. How about the cephalic phase, you guys? Well, loss of appetite and depression, that can play a role.